Hello, my name is Ilona Frieden, and I am a professor of dermatology and pediatrics at the University of California, San Francisco, where I previously served as division chief in pediatric dermatology and vice chair of dermatology. Today, I'm going to be talking about one of my favorite topics, which is advancing care for patients with infantile hemangiomas. Infantile hemangiomas are a very common birthmark, estimated to occur in about 4% of infants. And their incidence is higher, as we know, in preterm infants, in very preterm infants, even up to 15%. Um, we see these not actually at the first day of life, typically, but they may present as a very faint patch, red or whitish patch at birth, and then very rapidly develop into a bright red growth that is occurring over the first few days or even few weeks of life. Hemangiomas can also vary a lot in their appearance. They can be bright red and are sometimes called strawberry birthmarks because of their characteristic bright red color. But deeper hemangiomas that are underneath the surface are often a little bit more blue in color and more present as a soft tissue swelling rather than as a discrete lump. They also vary tremendously in size, and they can be in virtually any location on the body. But for example, you can have a small localized hemangiomas that's just a few millimeters in size, or you can have ones that are many centimeters in size, often mimicking a port wine birthmark initially, but then proliferating and becoming thicker, so it becomes evident what you're dealing with is hemangioma. And this is a very important distinction because those that are more territorial, we call them segmental hemangiomas, can be associated with underlying structural abnormalities, whereas the very well confined smaller ones typically are not associated with any underlying abnormalities. The timing of when referral should happen is really one of the most important aspects of hemangioma management. And of course, it's going to depend on risk stratification. I want to emphasize what are some of the clinical signs that would prompt referral. I think these clinical signs really fall into two buckets. I want to emphasize first those hemangiomas, and they aren't very common, that can potentially cause life-threatening or functional threatening uh, problems, and then go to the more common reason for referral, the more common need for referral, actually, which are hemangiomas that can leave behind permanent scars. So some of these include, for example, if a hemangioma is, as I said, that territorial or segmental hemangioma in the beard area, these have a very high risk of concomitant airway hemangiomas. We know that if hemangiomas are directly impairing the visual axis, this can lead to permanent visual loss in infants if not treated. Those that are involving the lip or involving the oral cavity can lead to some feeding difficulties. And one of the most common complications we see of hemangiomas is ulceration, skin breakdown. Really, any central facial hemangioma, even if quite small, even if, for example, only a centimeter if a child is less than 3 months of age, particularly if it's located in the central face, um, can end up leading to scarring, which can be difficult to hide and is really unfortunate, particularly since we have highly effective treatments for hemangiomas. There are tools to stratify between those that are small and innocuous and those that are more threatening. Two of the major tools that we do this with are an online tool called the Infantile Hemangioma Referral Score, which takes only a matter less than a minute to answer the questions relevant to whether or not this hemangioma is higher risk and which can be used by any physician. The American Academy of Pediatric Guideline risk levels, again, stratifies according to four main categories: highest risk, high risk, intermediate risk, and low risk. The highest risk are patients who would have functional impairment or underlying structural abnormalities. So these would be patients who might have a hemangioma closing the visual axis, which can lead to permanent visual changes. A hemangioma, where you have multiple hemangiomas on the skin, might herald liver hemangiomas, which could require intervention. Also, hemangiomas that are extensive, involving the perineum or the face, where there might be underlying structural abnormalities such as face or lumbar syndrome. And those really constitute the highest risk group, and very prompt referral is needed. In reality, although those are probably the most serious, the most common need for referral are the high-risk hemangiomas, and those are the ones that, although they are not life or function threatening, can leave behind permanent life-altering skin changes in the form of scarring or anatomic distortion of landmarks. And so these are also very important, and these may not be as dramatic. This may be only a small 1 or 2 centimeter hemangioma located on the cheek, which is an area which, if it leaves behind a scar, there's no place to really hide that hemangioma once these permanent skin changes occur. And then you get to a sort of gray area, and those are the intermediate risk hemangiomas. Those can be greater than 2 centimeters on the body, with or without ulceration. You may want to refer these because some of these patients do warrant treatment, but certainly not all. And then low risk hemangiomas are those that are relatively small, often in covered areas of the body that can be easily covered by clothing. Um, if parents aren't too concerned about these, we can often reassure that these will eventually involute, and often these children do very well. What we've learned over many decades now is that timing is key in the management of hemangiomas. Why? For several reasons. First, because we now know that rapid growth of hemangiomas is not a linear process. It occurs in an accelerated fashion over the first few weeks. And sometimes most of that growth is completely done by 1 or 2 months of age, and typically by 3 months of age. That's when intervention is going to be the most effective, and that's when patients need to be seen. And one of the things that means is that patients have to be moved out of a normal appointment queue and moved to the front of the line if they have a high risk hemangioma, because they need prompt intervention to minimize the impact of the hemangioma and to improve outcomes. As many of you know, there has been a revolution in the treatment of hemangiomas beginning in 2008, when oral propranolol was first described as a highly effective treatment for infantile hemangiomas. It is now the only FDA approved treatment, and it's extraordinarily effective in the vast majority of cases in shrinking hemangiomas, stopping them from growing, and preventing adverse problems such as scarring or other sequelae. People began to repurpose use topical beta blockers, particularly in the form of topical timolol and glaucoma medication and eye drop, to treat smaller, well-confined hemangiomas. And this is often used as well, although this particular medication is used off-label. It is not FDA approved. And it's used for hemangiomas that may not become as aggressive and don't require systemic therapy. So it really should be for very confined, relatively flat hemangiomas. And those that are more extensive or becoming thicker will require oral beta blockers. And then there are a smattering of other treatments that we do use at times, including corticosteroids, either intralesionally or orally, or laser treatments often used to mop up residual skin changes toward the end of the proliferative phase. But the mainstay of treatments are going to be beta blockers, either oral beta blockers or topical beta blockers. When you're treating young infants with beta blockers, you need to be aware that there are certain potential side effects. The medication propranolol is FDA approved for age 5 weeks or older, adjusted gestational age, but is sometimes needed for even younger infants. So that kind of decision needs to be made in conjunction with a hemangioma specialist, someone who is frequently using these medications. The side effects, while we used to worry that things like cardiovascular side effects, bradycardia, and hypotension might be the most concerning side effects, these turn out to be quite infrequent. Although the FDA mandates monitoring in the Office of Heart Rate and Blood Pressure, there's a large body of literature now to suggest that this is probably not absolutely necessary in very healthy, otherwise healthy babies. Although certainly we do check heart rate before we start them on medication, we make sure that they don't have any pre-existing cardiac disease. And in fact, the side effects that we think about most in terms of oral beta blockers are minor side effects. They would be things like cold hands and feet, minor sleep disturbances, typically, which can be mitigated with dose adjustments. However, we do want to really counsel parents about a couple of other medical concerns to be aware of. One is the risk of hypoglycemia, which is rare, but is certainly potentially very serious. We try to mitigate against the risk of hypoglycemia in a couple of ways. The main one is in patients who are not feeling well, not feeding well, we stop the medication until their oral intake is back to being more normal and then restart the medication, which is quite a safe thing to start and stop like that. Um, the second is to make sure that they don't have any other reasons for hypoglycemia, any metabolic disorders, for example. Another is that of wheezing. We know that beta blockers, particularly with viral illnesses, can lead to wheezing, and so certainly the medication should be stopped if there is wheezing. And then typically, though, can be restarted unless the baby has chronic asthma, can be restarted after they've gotten over an intercurrent illness. Timolol is a very potent topical beta blocker, and one needs to keep that in mind and confine the amount of timolol used to really only a matter of 1 or 2 drops once or twice a day. That would be a maximum for the vast majority of infants. This medication should not be typically used in open areas of skin, such as ulceration, where systemic absorption will be greater, because we certainly don't want to make the mistake of giving a medication topically and inadvertently having it become a systemic medication. There are a few other treatments that clinicians should be aware of that can be used in the treatment of hemangiomas. Two of these are other beta blockers other than propranolol. Atenolol can be used in babies where wheezing is an issue, and this may be particularly true for preterm infants who have chronic lung disease, where atenolol might be a better choice as a selective beta blocker. Nadolol does not cross the blood-brain barrier, and for babies who are having a lot of issues with behavioral changes or sleep disturbances, nadolol could be considered. But a caveat to these medications is that both of these typically would need to be compounded as opposed to available in a liquid formulation, which can introduce complexities. In terms of other emerging treatments, sirolimus is being considered as a backup for those rare hemangiomas that do not respond to propranolol. It is an mTOR inhibitor and it's used widely for other vascular anomalies. And there's limited evidence that it may be helpful for those hemangiomas that are not responding to beta blockers, although that situation is quite uncommon. Parents can be very, very frightened by hemangiomas, especially in a baby who starts out with no hemangioma and then this growth rapidly emerges. Um, and I think doctors can use resources that are very helpful to parents to try to put in context their specific child's hemangioma. What are the characteristics? Where is it? Does it need intervention or does it fall into a low risk category? And there are online resources that we can turn to and we can tell parents about. The Wikipedia infantile hemangioma entry is a very good one and widely available. Another example that can be helpful is a website called hemangiomaeducation.org, which I have been involved in creating, which has lots of good quality and up-to-date information about hemangiomas, and importantly, also has a video for caregivers who are going to be giving oral propranolol, which many of our patients find very helpful to go through before they're going to be starting a course of oral propranolol. The American Academy of Pediatrics has a healthychildren.org website, which has good information, and the Society for Pediatric Dermatology has lots of good patient information on hemangiomas and on ulcerated hemangiomas as well.